All right, that concludes Module 2. So any questions from the audience regarding the content that was in Module 2?
Thanks for that session. This is the question from the naive epidemiologist. In terms of the side effects, particularly the longer term effects, how unique are they to, say, CAR T type treatments versus sort of chemotherapy, other sort of modalities that you'd see in oncology in treating these patients?
Based on the clinical literature right now, these are not necessarily for CAR T specific per se, mainly because a lot of our patients are heavily treated with the other chemotherapy agents. So literature says now that we have pretty much about the same rate with the other chances of getting a secondary malignancies. But we are learning more as these are newer agents. And I recently read the articles we are mentioning about T cells malignancies, but these data are coming out. So we'll be learning more. So the key here at the moment, we are focusing on surveillance, being aware of these. And we also have a lot of long-term follow-up clinical trials that we're enrolling patients on. So these are evolving knowledge at the moment.
So maybe following up Jeff's question, I'm also a naive epidemiologist as well. I'm just thinking when you're talking about the similarities with other oncology treatments and the presence of infections, has anybody gone back to the original, investigational drug stored specimens and see if there are any of the viruses in that stored specimen that could have been infused into the patient and then have some sort of latency period before, appearance in the patient?
I believe they have data on those, and with the newer CARs, the generations, these are very minimum in terms of the viral systems that is built on the CAR T cells. So I think the data are showing that is very minimum in terms of viral infections that can happen from that. A lot of the virus infection that we're looking at in our patient that I'm seeing is they are generally like RSV, CMV reactivations type of infections. And these are mild and moderate, and generally they don't require hospitalizations.
We were just to add to that, saying that all the quality checking is done prior, and so these products are tested for all of these things before we infuse.
So I think we would have to separate commercial products from trial products. So I think with the commercial pharma products, there's a quality systems check prior to the product being released, which is done prior to ensure there isn't any contamination of the product prior to being sent back to treat the patient. I don't have an answer for the research side. I'm guessing maybe Araceli, if she was here for the GMP side, would be able to probably answer more of their process prior to releasing products that are being utilized in clinical trial settings.
We have an online question. Are there any recommendations regarding checking titers or repeating vaccinations in CAR T-cell patients similar to what is done in HSCT patients?
A really good question. So Chelsea referred to the ASTCT, which is started as the transplant organization, is now incorporating cellular therapy. So the infectious disease portion of ASTCT is starting to develop vaccination guidelines post-CAR T-cell therapy as recommended, because a lot of HCT programs branched out or incorporated IEC infusion initially, but now that there are more products and they're learning more about how the patient's potential infections post-CAR T-cell therapy, there are guidelines being developed for post-IEC therapy vaccination scheduling.
A lot of time is also these are patients that our B cell activities are not quite there yet post-CAR T. So the vaccinations, the questions is like a lot of our physicians might decide to check their B-cell activities and before we revaccinate these patients. And we do check frequently for like CMV titers, follow-up, and then make sure we treat them early on so that they, this does not become an uncontrolled disease.
I have a case study that I tabled. So here we are. Let's do it. That we could do one case study, maybe a couple case studies, one on CRS and one on ICANS, just kind of pull everything together at the end of this module here. So this patient is an 18-year-old male, history of pre-B-cell ALL. At diagnosis, he was CNS2. He was referred to our institution for CAR T-cell therapy for relapsed and refractory disease. So his pre-CAR T-cell disease status, his bone marrow biopsy was done that showed 77% blasts in his marrow. The LP was negative. So he received lymphodepleting chemotherapy with fludarabine and cyclophosphamide per protocol and received CD19 directed CAR T cells on our Kymriah protocol. So this patient on day +5 following his infusion began to have symptoms of CRS. He initially developed fevers of greater than 39 degrees Celsius. He developed an oxygen requirement with 1 liter nasal cannula, and he became hypotensive and was not responsive to normal saline boluses and ultimately required the initiation of dopamine for pressor support and was transferred to our pediatric ICU. Lab work was monitored throughout this time that showed significant elevation in his inflammatory markers, including his CRS and his ferritin, and his CRS resolved by day +10. So looking at this patient's clinical markers and factors, you can see that he developed ultimately grade 3 CRS. Initially with the fevers, that would give him grade 1. But then he developed this low-level oxygen requirement under 6 liters, so that would put him at grade 2 CRS. And then because he was hypotensive but didn't respond to this initial normal saline bolus and ultimately required dopamine, that gives him grade 3. So luckily, we were able to manage this patient with all of the appropriate medications that we discussed. Tocilizumab was given. I don't believe this patient developed any ICANS. He didn't require the initiation of steroids. He responded to that initial management, was monitored for a few days in the ICU on his pressors, and was ultimately able to be weaned off. And by day 10, as I said, his CRS had resolved. And he was able to be discharged within a few days after that.
I think a couple of other points that may have been touched upon earlier in the day, but just to follow up regarding patient and caregiver education. I think Sarah mentioned that wallet cards are required. So each one of the FDA approved products has its own wallet card. And what is included on that wallet card are the signs and symptoms of CRS and ICANS, and that the patient should report immediately to their provider if they experience any of those. And then I think the slide that Dr. Buddy had this morning regarding how many people are involved in caring for this patient population and the education and heightened awareness around the point of entry at the institution where a CAR T-cell patient may be seen, and making sure that those providers are aware of ICANS and CRS and how to appropriately treat those patients and identify those and call in the right support and other services that may need to be included in the care of that patient. Because I think oftentimes, or if the patient has been transitioned to the community and has late onset ICANS, having that wallet card to notify whoever is evaluating the patient that this could be a side effect of their CAR T-cell therapy and not, an embolic event, a hemorrhagic event, or some other, I think patients have been tested for tox screens when they present with ICANS, because that's kind of the go-to sometimes in EDs of when they present with peculiar behavior, ruling that out. So I think a lot of education and ensuring people at the point of entry at the institution where these patients may present are aware of what the signs and symptoms are and how to quickly treat them.
Yeah, I think it's really important for the people who are coming across with our patient who receive the CAR T cells, because in our experience, even out in the community, for whatever reason, patient may end up in the community ER setting, and they present like they're having septics, and people are being treated as just as a infectious workup. And it's really important for patients, and at that point, it's probably family members advocating for themselves and reach out to the hematology, and that's actually can save life, mainly because our physician then actually can guide them how to treat them, and then urgently transfer to our care so that we can probably manage these in the proper setting. So that's really important for awareness, not only for us, but is in the community setting as well. So thank you.